Good afternoon. Thanks for coming back to the annual conference Liver Connect. This is the 6th year. I remember the first year in 2020 when we were all dealing with COVID. In fact, I think it was the first live meeting in hepatology that year. A lot of my friends remember that. So this has been an incredible journey over the past 6 years, and I'm delighted to see a lot of people. I know people are still in some advisory boards and some other meetings. But as you know, this is a joint conference provided by MER, Medical Education Resources, and Chronic Liver Disease Foundation. We have a program that you'll see that covers really the entire spectrum of liver disease, primarily in the area that's more important for your practice. And of course, the target audience is not only our gastroenterology and hepatology colleagues, as well as our APPs and others. This is the agenda. Of course, in the morning, we had a number of sessions that were supported by our partners in the industry. We will start by giving a tribute to really one of the giants in the field of hepatology, our beloved friend, colleague, member of the board, Dr. Bruce Bacon, and Dr. Kim Brown will provide that tribute. Then we'll go to the viral hepatitis session, and the first talk there again is a memorial talk for Bruce again, one of his friends and colleagues who's also himself a giant in the field of viral hepatitis, Ira Jacobson, will provide. We have sessions in pediatric today in terms of cholestatic liver disease, autoimmune cholestatic liver disease, and then of course we will wrap it up in the evening. I think Ajaz is here, or somebody else will be doing the wrap up. And don't forget that we do have actually an industry program on PBC that Marcella Kugelmass will provide at the end, and of course we have a welcome reception that starts in late and sort of early evening. The day tomorrow starts with a meeting for our APPs and also another industry-sponsored meeting on MASH, and then we'll go to MASH, MASLD, and MET-ALD programs, and there we have a number of experts, both in MASLD, MASH, and also MET-ALD, again, another industry program, and poster sessions, and we go to ALD, and the day will be wrapped up by Dr. Stephen Flam, one of the members of our board. We do have top sponsor reception tomorrow evening, and so that would be part of what we will do, and of course, Saturday is going to, again, will be a very exciting day with another industry-sponsored program, followed by our final session that's going to be led by Dr. Marcella Kugelmass, Kim Brown, and Sami Saab, going through issues of cirrhosis and its complications. I think it's really built through a case, which is going to be wonderful for all of us to participate. And finally, Kim is going to summarize the entire meeting as the last part of what we do. This is the planning committee. These are members of the board of trustees. They do the work. I'm just a sidekick with them. So they are just wonderful colleagues to work with. I'm not going to go through the objective of educational meeting. This is sort of similar with what you've seen before. Of course, it's an accredited program with 9.5 AMA sort of credits that you can actually get category 1. But you have to actually complete some of the requirements to get the credit. Our disclosures are here for the board members who are also co-directors of this program. MER and CLDF really don't have any other financial relationship to disclose, and of course, at the end of the day, we provide some the venue and the opportunity in the program, but the ultimate recommendations will come from the faculty, and it's really faculty's sort of perception and opinion of the topics they are talking about. We are grateful for our sponsor for at least the educational grant sponsor support from Orphalin and Salix Pharmaceuticals. They've actually supported this part. Of course, we have other sponsors that we will also show you. This is how you claim the credit, and if you actually scan that and do the pre-test and post-test, you can then claim your CME credit. You have until April 13 to finalize that. This year we've been very lucky to have a number of platinum sponsors with Gilead, GSK, Ipsen, Madrigal, Novo, gold sponsor with Salix, and of course we have a number of silver sponsors that are listed here. Thank you to all of you. Without their support, obviously, we cannot have a meeting, and this venue has been, of course, a fantastic venue for all of you and all of us. This is a new thing that's called Promptive, sort of a platform that's actually created by CLDF to create really a discussion amongst colleagues about any topic that you want. So every morning you will have a topic that's actually being talked about. It will take only a few minutes to respond. You can respond the entire day, obviously, and the participation will come with an email that you can click on the link and actually join. The purpose of this is really to get your sort of input about how we should do this in the future, what will benefit you and our colleagues and the field. Some housekeeping issues, Q&As. There are actually, you have microphones in every aisle. Of course, you can use those. Please support our sponsors. Just go to the exhibit hall and show our appreciation to them for supporting us. Wi-Fi, of course, is available if you're staying here overnight. That's available, and as I suggested earlier, there's an event tonight at 5 p.m. That you can 5 p.m. is actually our dinner presentation with Marcelo Kugelmass, followed by our welcome reception. So with that, I'm going to ask Dr. Kim Brown, who really does not need introduction. She's a leader in the field of hepatology, really a wonderful speaker. Was the previous chair of the Department of Gastroenterology at Henry Ford, and current president of the AASLD Foundation, but a member of the Board of Trustees. And she has been a friend and a colleague of us for many years. So she will be giving the tribute for Bruce Bacon. So Kim, thanks for taking the podium. Thank you.
Well, Dr. Bacon was a transformative figure whose impact has really been felt throughout the field of hepatology. His pioneering work as a researcher, an educator, and as a clinician fundamentally changed the practice, our understanding, as well as the advancement of liver disease in this country. Dr. Bacon's influence extended from the laboratory bench to the bedside, leading to breakthroughs in scientific knowledge, the establishment of leading medical centers, and the creation of enduring educational initiatives. His dedication to patients, his mentorship of future leaders, and his prominent national leadership roles not only elevated the standard of care, but also fostered a sense of curiosity, compassion, and excellence. Through his visionary leadership, Dr. Bacon changed the trajectory of hepatology for generations, leaving a legacy that continues to inspire and guide the field today. Dr. Bacon's academic journey began with a Bachelor of Arts from the College of Worcester in 1971, followed by a medical degree from Case Western University in 1975. He launched his academic career in 1978 as a teaching fellow at Case Western, and later became a professor there before moving to the Louisiana State University School of Medicine in 1988. In 1990, he joined St. Louis University, becoming a central figure in the Division of Gastroenterology and Hepatology and holding the prestigious James F. King Chair in Gastroenterology. Dr. Bacon's scientific contributions during his time were both groundbreaking and enduring. From 1982 to 2007, his NIH-funded research on iron-induced hepatotoxicity and hepatic fibrogenesis set new benchmarks in the field. In 1996, he was part of the team that discovered the gene for hemochromatosis. This was a milestone in medical genetics. As a clinician, he was among the first to identify and describe non-alcoholic steatohepatitis, which may be news to all of you. But this really paved the way for the advancements we are now seeing, both in terms of diagnostics as well as treatments for this disease. As an NIH-funded researcher for over 25 years, Dr. Bacon authored more than 350 works, including articles, reviews, and book chapters. He also co-edited major textbooks that we continued to use as practitioners and for trainees in the field. For 35 years, Dr. Bacon dedicated himself to St. Louis University, where he not only built but led the academic and clinical division of gastroenterology for over 2 decades. Collaborating closely with Dr. Adrian DiBisegli, they founded the St. Louis University Liver Center in 2000, and under their leadership, this became a center of excellence in 2001. The center grew into a world-renowned institution recognized for pioneering patient care, groundbreaking clinical and basic scientific research, and public education in liver disease. Their work played a major role in advancing the treatment and cure of hepatitis C and drew international attention, helping patients, including some well-known figures, to find life-changing care. Dr. Bacon was also one of the early leaders of the Chronic Liver Disease Foundation, helping shape the organization into a vital resource for clinicians nationwide. His vision supported the development of enduring educational programs, such as Liver Connect, that continue to elevate the standard of care in hepatology. Through his guidance and commitment to clinical training, this foundation has built a legacy that continues to strengthen the field today. He was revered not only for his scientific achievements, but also for his extraordinary education and dedication to patients. He possessed a rare combination of deep clinical knowledge and a remarkable ability to connect with the people that he cared for. Over his career, he treated thousands of patients, many of whom spoke with gratitude and admiration at his memorial, which was really a testimony to the profound impact he had on their lives. On the national stage, Dr. Bacon was a respected leader. He served as the president of the American Association for the Study of Liver Disease, and he chaired multiple boards of the American Board of Internal Medicine. He played a pivotal role in establishing transplant hepatology as its own subspecialty. His service was recognized through numerous honors, including the AASLD Distinguished Service Award, and he was designated as a Master of the American College of Gastroenterology. Dr. Bacon was a mentor of exceptional generosity, shaping the careers of junior faculty, trainees, and students, and fostering always a culture of curiosity, compassion, and excellence. Like many others, I considered Bruce to be a mentor. He was remarkably generous in giving opportunity to young hepatologists, including inviting me to sit on the first transplant hepatology board. I will never forget the many meetings that began with Bruce reminding us to leave our egos at the door, always being serious. Of course, that never truly happened, and the loudest and the liveliest and the most spirited discussions were always led by Bruce himself. He took great pride in crafting meaningful and impactful exam questions, and he was always the most animated member of the group when we worked to reach agreement on the correct answer. Those moments brought laughter and learning, and this reflected his deep commitment to shaping the next generation of our field. Dr. Bacon retired from SLU in 2020 and left behind a profound legacy of scientific advancement, compassionate care, mentorship, leadership, and service. He will be remembered always as an extraordinary physician, a brilliant researcher, a dedicated teacher, and above all, a deeply kind and thoughtful human whose life changed the course of liver disease treatment for generations to come. He will be greatly missed, and his contributions will continue to touch lives long into the future. And so if I could ask just for a moment of silence. Thank you. And now I'd like to invite Dr. Ira Jacobson to give the Bruce Bacon Memorial Lecture on Viral Hepatitis in 2026. Dr. Ira Jacobson is professor in the Department of Medicine at NYU Grossman School of Medicine and the Director of Clinical Research Hepatology Program in the Division of Gastroenterology and Hepatology.
Well, thanks so much, Kim. It's wonderful to see everybody here. I think the program is terrific. The location is equally so, and we're all going to have a good time together. I hate redundancy, but I'm going to have to be a little bit redundant for two reasons. The first is that when I began to prepare for this program today, and specifically the lecture to follow, I didn't see Kim's name ahead of mine as giving a tribute to Bruce. But even once I learned about that, I didn't cut off what I'd already created, because I too had a special relationship with Bruce. He was a mentor, a friend, and many other things, a wise, wonderful guy. And I'll say a little bit more about that. But I'll do it quickly in deference to Chris's lovely memoriam to him. So these are my disclosures. And in written form, this is what Kim said. Bruce attained an astonishingly high level of prominence, prestige, and accomplishment in the hepatology field. His accomplishments are listed here. I'm certainly not going to go through them. I have to personally recall the time that he called me when he had just become chair of the ABIM Transplant Hepatology Committee. And he called me, this is a true story, and he said, "Ira, I need you to be on the Transplant Hepatology Board." I said, "But Bruce, you know very well that I'm already on the GI ABIM board. That's a bit much, don't you think? And are you aware of the fact that I'd have two separate positions with ABIM? Is that allowed?" He said, "Not only is it allowed, but I need you to do it because Emmett Keefe, who at that time was already a venerable, beloved hepatologist, who many of you will remember, he said was too busy to do it. He was the other hepatologist on the GI board." And I said, I knew it would be fruitless to try to compare hour for hour how busy we both were. I just said, "Well, yes, Bruce, of course I'll do it." And I learned a lot, but the irony that has occurred to many of my colleagues and friends is that I'm not a transplant hepatologist. And more than once, people would come up to me and say, "Ira, why is your signature on my new board certificate for transplant hepatology?" And I would tell them the truth. And I also learned a lot. For some of you who took the test in the early days, I was responsible for a good number of the viral hepatitis questions, so I hope you found them to be reasonable and fair. And that was Bruce. You didn't say no to Bruce if he asked you to do something, and you wouldn't want to. All these other accomplishments and awards are astounding in their scope and breadth. He published hundreds of papers. These are the ones listed in PubMed, about 300. And you see all the qualities at the bottom. In fact, if you read it carefully, I felt that he was such a wonderful innovator, I accidentally put it in twice, but I think subconsciously I wanted to emphasize the point. He was a true physician scientist. Kim mentioned his pivotal contribution to the hemochromatosis field, but he was also a family man. He adored his wife, Sarah, and his kids, and we would talk about our mutual families frequently, and he was a friend. At many of the international and national meetings that we attended together, it became a regular event for me to sit with Bruce beforehand. We'd make time to talk to each other, and even though we weren't that different in age, he really was kind of a mentor to me. I remember the time in the early 2000s, he said, "Ira, you've got to stop doing all these ERCPs and just focus on hepatology." And not too long after that, I did, having initiated a process of thinking about that after he suggested it. He immediately thereafter started telling me, "You've got to stop doing colonoscopies and endoscopies. You're known as a hepatologist." And in fact, next month, after 21 years following Bruce's giving that advice to me, I've decided to do that, and I'm looking forward to it. These are some of the papers that substantively add to what Kim said about the scope and versatility of his academic achievements. And there are so many wonderful tributes from patients that I couldn't resist sharing with you, and I'll just give excerpts of a few of them. I've just learned of the passing of this wonderful, compassionate man. The world lost a great human, a true angel. I'm eternally grateful that God put me in touch with this wonderful man. My mother only said wonderful things, etc. What a caring, intelligent, and gracious man. Every visit was as if you were the only patient he had on his agenda, and that's how I felt when I talked to Bruce, particularly when we were talking about deeper things like professional advice and family matters. Heaven is a far more loving place in his presence. And finally, such a sad passing. What a guy. Dr. Bacon saved my life, always had a smile, plain-spoken and caring. Thank you, Doc. And finally, there was one comment online that said, "The best doctor I've ever had, rest in peace." And so may Bruce rest in peace. I do want to share a bonding experience I had with him back in 2010 when the volcano blew up. Some of the older people here may recall that, and the quandary we were all in when we had to decide how to escape from Vienna, which wasn't going to be easy. Well, on Sunday morning, the morning that I was supposed to have gone home, and had absolutely no idea how I was going to get home, with many things waiting for me on Monday, including my daughter's visit to the college that she wanted to go to, that I really wanted to be part of. I went to a Gilead meeting that morning. I hope I'm allowed to mention corporate entities in this context, Zobair. And I heard whispers about them having a bus that was going to go to Barcelona, which is the only city at that time from which planes were able to get out because the volcano cloud hadn't gone that far south. Well, I made it my business to nudge Gilead enough to get me on the bus. I've never forgotten that. And there were 3 of us on that bus. Bruce, sitting next to him was me and Dr. Eugene Schiff, who you all know, and is also one of the great figures in hepatology of the last few decades. Well, if you go for 26 hours on a bus ride through 4 countries to get from Vienna to Barcelona, you bond with the people that you are traveling with, especially because there's not much sleep time. And we parted ways, but that's when my relationship with Bruce became even deeper. We'd shared many thoughts, as we had continued to do in the years after that. So I thought about what to discuss with the assigned topic of viral hepatitis, and I first thought, well, I'll give the highlights for every virus for which we have a letter. And they said, no, that's ridiculous. Some of the viruses are much more topical than others. And I'm going to talk about viral hepatitis B and D, with apologies to those of you who think I should have covered hepatitis C, for example, which we were also involved in years ago. And I want to start with the new practice guideline on the treatment of chronic hepatitis B. If that's all I talked about, perhaps that would be enough, but I'll go beyond that. And there were 6 questions that they did. This was an innovation that we haven't seen before. The questions I will go through one by one, so I won't read them off to you here. But the main new feature was incorporation of, quote, shared decision-making on key issues, like what to do with immune-tolerant patients, where the dictum from the ASLD used to be, don't treat these patients. So question 1 is, what's the optimal antiviral strategy for pregnant individuals with viral levels above 2,000? And the answer now is continue therapy if on TDF or TAF, if on entecavir, switch. And then at the bottom, I've highlighted in blue the main points that I take away from this. TDF and TAF for breastfeeding don't use entecavir, and we all know there's a lot less data on the safety of entecavir than tenofovir in that setting. But to me, the main point of this was to finally codify as safe the administration of entecavir to pregnant women. How many of us used to struggle if we had a viremic woman come in the first trimester and have to decide whether to stop her therapy, that is highly viremic, before the therapy had started working, tenofovir or entecavir? And so they're telling us basically, yes, we, the ASLD, say that it's safe. You don't have to be in a quandary about that issue anymore, which had always bothered me. And the same thing for breastfeeding. Calvin Pan, who has come to these meetings in the past. Calvin, are you here? I wanted to pay tribute to Calvin for almost, and not quite, single-handedly defining what we do for pregnant women, or women who want to become pregnant. And so I thought I would just add that tribute to him. He's a colleague of mine on the clinical faculty at NYU. Question 2, should antiviral therapy be provided to people who are S positive with viremia that don't meet disease-specific treatment indications to reduce transmission in high-risk scenarios? I think this is one of the less urgent topics that we have to decide, but it's important. And again, that phrase shared decision-making, which I underline because it's so pervasive, which is a good thing, through these guidelines. And they define which exposures warrant antiviral therapy for its own sake. And interestingly, and I think we're used to this by now, the CDC and the Society for Healthcare Epidemiology in America recommend against disclosure to patients and staff, which was always a real quagmire for people who are infected in the healthcare professions. Should individuals in the immune tolerant phase start antiviral therapy versus observation? This is a time-honored controversy. Do we treat the virus or do we treat the state of liver disease? You have to have active hepatic inflammation or not. We've come more and more to worry about the biological events that occur in cells, particularly with relationship to HPV DNA integration and potential oncogenicity later in life, and that's why they've become a little more liberal about this, having always previously in the guidelines every year say no, or every version of it would say, no, these patients don't need to be treated. There's no evidence that it improves clinical outcomes. We were never going to get such evidence because you'd have to do a 30-year study on 1,000 people. So ASLD suggests antiviral therapy if you're over 40 or significant liver inflammation or fibrosis. Well, that's easy. That's an easy way out. Of course we would treat those patients. It's not controversial. But most Immune-tolerant patients are under 40. They don't have fibrosis, or they don't have stage 2 fibrosis, if any. And is ALT alone sufficient to grade inflammation? Some studies showed that there can be some inflammation in people we used to call immune-tolerant. For those under 40 years, therefore, they said, finally, shared decision-making with consideration of risk factors and benefits, risks of treatment. And I wonder how many of you may have been influenced by this in your decision-making. I've been treating these patients for years because of concerns about particularly oncogenicity later in life. Of course, close monitoring if not treated. This is a landmark paper from William Mason and Patrick Kennedy and others. I'll come across Dr. Kennedy's name in a little while again. The special problem of immune-tolerant patients. So they studied 26 patients, including 9 e-antigen positive, which they are, by definition, immune-tolerant patients. And they found a high level of viral DNA integration randomly distributed among chromosomes in all 3 groups, clonal hepatocyte expansion, which conceptually at least sounds like a potential precursor to oncogenesis, in immune-tolerant patients to a greater degree than expected, and HBV-specific T cells detected in the blood of patients with all 3 phases. And so they postulated that hepatocyte turnover driven by the immune response, may be driving this clonal expansion of hepatocytes. And the most wonderful line in the paper that I think endures to this day is, quote, withholding of antiviral therapy in immune-tolerant patients, at the very least, I would add, requires reconsideration. And I wonder what the practice patterns here are. Who here treats immune-tolerant patients with hepatitis B with antiviral therapy? Okay. Who has those patients but doesn't treat them with antiviral therapy? Okay. I don't know how many of you are seeing hepatitis B patients. Maybe I should stop now. But this idea that you're slowing down what might be an oncogenic process later in a person's life, I think still holds and was supported by 2 studies in 22 and 23 in the ID literature. This one on reductions of integrations in hepatocyte clone size and antiviral therapy, and you see the 2 sets of graphs vertically. One is integrations, one is maximum hepatocyte clone size as a possible precursor to a clonal expansion of hepatocytes that might become malignant. These were 28 patients treated with antiviral therapy, and all 28 were evaluated at year 1 and had statistically significant reductions in the number of integrations and in the maximum hepatocyte clone size. And then 7 were treated all the way out to year 10, but still almost attained statistical significance with regard to DNA integrations, and did achieve statistical significance in terms of reducing maximum hepatocyte clone size. So these 2 studies have often been added to the arguments that have been made over the years amongst those of us who favored treating these immune-tolerant patients. And this is a second study that was actually tenofovir versus placebo. It's an offshoot of one of the giant trials that got tenofovir to the niche that it has now as a drug of choice for hepatitis B. And they showed that in the tenofovir group, TDF specifically, but I don't think it matters, was associated with a decrease in integration of HBV DNA compared to placebo. So as I was starting to say a moment ago, these 2 studies together have added fuel to the arguments of those who feel that these patients ought to be treated, and that in fact we should think of hepatitis B as a disease meriting antiviral therapy because it's a viral infection, as opposed to just an inflammatory liver disease, that harms might come to patients who aren't treated timely at periods in their life when they're highly or moderately viremic. So many of us are coming to see hepatitis B as worthy of treatment if there's active viral replication, independent of indices of inflammation and fibrosis that may prevail at that point in the person's life. 4th question, this affects all of us and our patients. Should S-positive, E-negative individuals without cirrhosis in the indeterminate phase start antiviral therapy versus observation? And so first you have to see what they mean by indeterminate. And you see that I have arrows pointing to the 2 categories. 1, DNA less than 2,000, ALT greater than upper limit of normal. Well, here we all know the important thing is to make sure nothing else is going on. We always check for HDV routinely. I hope you're all doing that now. But Hep C, other things, particularly fatty liver disease, and you know all of the rest. And the other category that they called indeterminate, which is the more problematic one from my perspective, is DNA greater than or equal to 2,000 IU per mil, ALT less than twice normal. Where does the twice normal come from? I looked at the text underneath. I didn't really see an explanation explaining why they came up with twice normal. Twice normal used to be the thing from the ASLD and EASL guidelines when it came to treating E-positive patients, where the only ironclad indication for treatment was an ALT more than twice normal. And that comes from this older concept that we should think of hepatitis B as an inflammatory disease that needs treatment for that per se. So I'm a little sorry they put that in. And I think indeterminate patients are actually not only people with HBV DNA who have any elevation in ALT, but what about the patients we see with 3, 4, 5,000 IU per mil who have normal ALT levels? That to me is the indeterminate phase, but it's not clear how they categorize those patients. They don't address that specific point. And many of us have expanded our concept once again, not only in the E-positive immune-tolerant patients, but in hepatitis B as a viremic disease when it's in that phase that probably warrants treatment. So again, they allow for shared decision-making, and they do say that individuals with persistently elevated ALT but viral DNA less than 2,000 should be evaluated for other causes of liver injury and managed accordingly. This is a paper, again, from the aforementioned Patrick Kennedy, who's this fantastic and world-leading viral hepatologist, if I may call him that, in the UK. I've been privileged to become a friend of his, and we go to meetings together and participate in things. And he's the one who co-authored, if you recall, that study I just showed you a few minutes ago on immune-tolerant patients. But this is a beautiful list of all the guidelines compressed into one space, which very few people have managed to do so clearly. And the thing I want to point out to you is that in 2022, for those who don't know already, the new Chinese guidelines came out, and they said notably that if there's any detectable HBV DNA with normal ALT, if you're over 30 years of age, you should treat those patients. So there's a patient like the one I saw the other day who had 500 IU per mil normal ALT, and I actually decided that what I haven't done in the past so much is to apply the Chinese guidelines to him because he is Chinese. I think this may apply to people who have been infected most or all of their lives, such as is so prevalent in Asia compared to adult transmission, which is more often a cause of indigenous Americans, if you will. I don't know if that's the right phrase, but people who haven't come from a high-risk country, a high-prevalence country in their adult lives. I don't necessarily apply this to all of these patients, but it's thought-provoking. Is any level of viremia at all worthy of treatment, regardless of the absence of liver inflammation? And that's what the Chinese guidelines say. And they list in the same paper, Dr. Kennedy and Associates in The Lancet, where that paper appeared, the pros and cons of expanding treatment for chronic hepatitis B. Well, first of all, you can see the arguments in favor greatly outnumber the arguments against. We don't have time to go through these individually, but if you were to do so, you would see that there are many more substantive biological arguments as opposed to arguments about potential resistance, which really is not an issue with our current treatments. Or other factors that really are more theoretical than anything else. Significant flares can occur upon nuke withdrawal. Yes, that can happen in patients who don't comply and don't let you know that they're going to stop. We have to acknowledge that. But all the biology is on the other side, and that's what I wanted to leave with you. Question 5, should S-positive individuals without cirrhosis who've been on a nuke for at least 3 years and are S-negative with undetectable DNA remain on or discontinue therapy? And AASLD makes it very easy. They suggest not withdrawing therapy until HBsAg loss. The new EASL guidelines say that if you're under 100, that it's a viable option. It's not clear. They have it in their algorithm as kind of the thing to do, but I don't think they mean to say that as a dictum. I think it's simply a more flexible approach to these patients. And the reason for that, as you well know, if I can just insert one more comment here, which is that the slide has dropped out. I had the slide from the Giroud study in 2021. I proofread everything this morning, showing that in a very large international cohort called the RETRACT-B cohort, they actually found that patients who stopped therapy as a deliberate strategy to provoke an immune response and knock out the infected liver cells, even though you can get a hepatitis flare, worked very well in people from Asia under 100 IU per mil, and in Caucasians, it was about 33% in the Asian patients, 41% in their cohort of Caucasians, if you were under 1,000 IU per mil. So it's a little more permissive when it comes to ethnicity. Nobody else has really suggested that yet, but that emanated from their database. So should we be doing that in clinical practice? And that's what this is really all about. Well, they did caution that there were hepatitis flares. You have to watch for ALT flares carefully if you engage in this strategy, and they can be dangerous, and you should not do it in older people, cirrhotics, or anybody with an S antigen level over 100. My practice is more in line with the AASLD. I offer patients the option, but by the time we get finished talking about it, most patients say, "Doc, I'll be happy to continue the therapy." So takeaways are, again, ASLD says don't stop. ESL says stopping's an option. I've talked about 100 IU as the inflection point if you'd like to discuss this with your patients, and I think they are entitled to at least a discussion of that option. And don't stop if advanced fibrosis, I would say even F3 or F4 are present, and you have to monitor for flares carefully if you do decide to engage in that strategy. So actually, this is where my slide ended up, but I've already told you about the HEROD study, not Gerode, HEROD, excuse me. And the last question, which we'll do very quickly, but comes up in practice all the time when we have a lucky patient for whom we've thrown a figurative party, celebrated that they've cleared HBsAg after being chronic carriers or even lifetime carriers. About 1% a year, but if you see enough patients, you'll see this, and I'm sure many of you have. Do you still surveil them for liver cancer? Very important practical question. And the guidelines in their sixth in the series of questions and answers say all persons with cirrhosis, which makes perfect sense, men over 40 at the time of S loss, women over 50 at the time of S loss. I tend to subtract 10 years from each of those, but that's me being very cautious again, not necessarily cost effective. And a family history of HCC. We all know that that confers a 2 to 3-fold risk if you have a first-degree relative, like a parent or a sibling, who's died of HBV-associated HCC, or who's had HCC. For patients with chronic B without cirrhosis but increased HCC risk, from an endemic country, men over 40 years, women over 50 years, should get HCC surveillance. From Africa at an earlier age. That used to be in there, then it came out the last time, and now it's back in at 20 years, instead of, like everybody else, 40 or 50. Family history of HCC, page B score, more than 10, perhaps some of you use that, Delta infection, and HIV co-infection. So now I want to, the second part of my talk, and I'll be as brief as possible, relate to novel therapies for hepatitis B, which is a very, very interesting, fascinating, and hot field right now. I've had the privilege of participating in that in various roles and continue to do so. Antisense approaches are being studied, and just to remind you, there are two major antisense categories that are used, siRNAs and antisense oligonucleotides. The small interfering RNAs are given pharmacologically as a duplex, double-stranded RNA that dissociate from each other. One is a guide strand that gets it into this thing that the enzymes in the liver use to form a RISC complex, RISC. And then the active strand is deliberately synthesized in order to bind by complementary Watson-Crick base pairing to the mRNA that codes for a critical sequence in hepatitis B surface antigen formation. So it's a knockdown of HBsAg, and antisense drugs are a little bit different. They're single-stranded RNAs that target the messenger RNA that I just referred to, and they're degraded by RNA ACE. ASOs require more frequent dosing. They stimulate more immunologic activity, including TLR, toll-like receptor activity. There are accordingly more adverse events, including some of an immunologic nature, and they have been associated, as you'll see in a moment, with a higher rate of clearance of HBsAg than siRNAs when each is given as a solitary therapy. There are a host of incredibly interesting new approaches to HBV treatment, including gene editing or epigenetic modifiers that I simply won't have time to discuss today, but are in early phase development. And of course, those are designed to target both the CCC DNA to hopefully eliminate it and to at least silence the integrated DNA permanently. And there are one or two drugs out there that are purportedly capable of doing this, but data are early and in progress. So this is the REEF-1 study that is the best known study on siRNAs and the regimen that was most profoundly suppressive of HBsAg levels in the blood. And I just say as an aside that when you reduce HBsAg, you're doing it to stimulate an endogenous immune response that has hitherto been suppressed by HBsAg, which has known immunosuppressive properties on T cells. The most effective regimen here was the highest dose of the siRNA that they studied, which then was called JNJ3989. All these patients took nucleotide therapy as well. There was one group called a triple group, but they gave a capsid assembly modulator that I'll mention in a moment, and that actually didn't work as well. And we haven't figured out why yet, whether that was just an aberrant observation because it hasn't been duplicated by others. So nice potential reduction in HBsAg, but perhaps because it lacks the immunologic heft of an ASO, can't do it permanently, and you see the returns of HBsAg, although they're fairly slow, and recent studies have shown that they sometimes never go back to the levels at which they were before. There may be a permanent effect that we don't fully understand, but that's clearly not the solo pathway toward curing this disease. So they've been combined with a lot of other drugs like interferon, which has found a niche back in again, even though we all wanted to get rid of it after the hepatitis C era. And remember an earlier Hep B era back around 1990 when hepatitis B was treated with interferon for a while. So this was a major publication in the quest for functional cure, the first antisense drug called bepirovirsen. And this was the trial. I just asked you to look at the orange group that got Bepi, as we call it for short, 300 milligrams, which is given subcutaneously, and loading doses were given. And at the end of the day, or the end of the 48 weeks, after 24 weeks of treatment, 24 weeks of observation, about 10% of the patients in that seemingly most effective arm had cleared HBsAg at the end of therapy and maintained that clearance after another 6 months. That's not the same as longer-term data about what happens when you stop a nuke and truly achieve functional cure, because functional cure is not only sustained HBsAg clearance, but it's in the presence or the absence of any ongoing therapy. And that's the holy grail in the field. And subsequent studies have shown that indeed sustained response here does usually translate into functional cure. The Be Well studies are 2 ongoing phase 3 trials that are very important. They include bepirovirsen alone in 300 milligram dosing, as I've shown you, no adjunct to that. They're all on nukes at entry, and they have excellent viral DNA suppression. Similar design, 24-week follow-up, but now another 24-week follow-up after you stop the nukes based on nuke discontinuation criteria. No HBV DNA, no HBsAg at week 48 after 6 months of no treatment. And this is the quest for functional cure in a phase 3 trial. The patients are stratified by HBsAg 100 to 1,000 IU per mil, or greater than 1,000 to 3,000. Well, why is 3,000 a cutoff? It's because in the earlier studies, the only patients who had a chance of eliminating HBsAg were patients with HBsAg levels less than 3,000. This is an ongoing study of a small and I will go back and say one more thing. I'm on their safety monitoring board, so I can't say anything more than that, except to tell you that there is a release in the public domain to the effect that at least the company perceives that it has favorable results, but no results were given. So we have to leave it at that today. But it's very exciting to even have the possibility of another alternative treatment that we can offer patients with clearance of HBsAg. Now, 10% of people won't be the defining point in this generation of treatment. Of course, this is something to work more on, but we'll see if it emerges as an option. I just don't know. Nobody does at this point. Well, remember that small interfering RNA that I showed you a few minutes ago? That was purchased by GSK from J&J for $1 billion with the intent of doing this study. 2 closely related small interfering RNAs that are abbreviated DAP and TOM, DAP-TOM is the product, given for 24 weeks to lower the viral level, the HBsAg level, I should say, must not confuse that with DNA levels, by about 2 logs, as you saw in that graph. And then, when there's much less HBsAg around, give the patient also 24 weeks of bepirovirsen, as we did in the study seen a moment ago, and then follow up, nuke discontinuation criteria will apply, and then functional cure. So it's a very, very important study. It's underway. There are no data yet, but stay tuned. This is another antisense oligonucleotide from a company called Osper Bio. It's been presented from phase 2A and 2B data, and they looked at 225 milligrams a week. They looked at 300 milligrams a week. That turned out to be better, and 24 weeks was better than 16 weeks. So let's talk about where that arrow is in the first figure, looking at the 2 24-week arms where the patients were given identical regimens of this drug weekly for 24 weeks. And now they've been followed out to 48 weeks with a sustained clearance rate of HBsAg, but not functional cure, I'd remind you again, of 27%. That's a nice number. Now, it's way, way premature to start comparing one agent to another, and we just have to wait for more data on this. The HbSAg level was less than 10 at week 48 at 50% in one of those two studies and 62% in the other. So even many of the rest are being left with profound viral suppression. What happens after that, how much it rebounds, we don't know yet. And satisfyingly, patients had significant rates of anti-HBs seroconversion. We don't need that necessarily, at least with nuke therapy. Sometimes when you give a nuke, it takes several years for the surface antibody to appear, and that's not essential to preventing relapse, but we all like to see it. It's telling us something about the humoral immune system conferring a benefit chronically. Capsid assembly modulator, pevifoscorvir, which inhibits the formation of the viral capsid that I think you're all familiar with, does something that nukes don't do. At least in this E-positive study, HbSAg levels went down over a 1 to 2 year period in by about 0.8 logs. It may not sound like much, but the way we read into this interpretively is that it may reflect depletion or at least silencing of the CCC DNA as opposed to the HbSAg coming off the integrated DNA. And that dichotomy is going to be a big challenge as we try to develop treatments that are designed to get rid of CCC-derived HbSAg, but maybe for some patients it'll be very difficult or impossible to completely eliminate at least the expression of integrand-derived HbSAg, as it's called. You can see much more profound inhibition in E antigen in the E-positive patients and core-related antigen, which is considered to be a pretty good reflection of the CCC DNA reservoirs in the liver. Finally, hepatitis D, which we all know is the deadliest hepatitis virus, as seen on electron microscopy on the left. And if you read about the viral life cycle, it's really very interesting, but I certainly won't go into that now. Remember, it's an RNA virus. It has a single-stranded RNA genome, and it requires HbSAg as its surface protein to encapsulate it. And bulevirtide, which I think most of you have heard of, is an entry inhibitor initially developed for hepatitis B, but it seems to work even better for hepatitis D. This is a drug that's been presented in numerous iterations over the last few years, and I for one, am not sure where it falls in terms of the current plan from the company to bring it forward. So they haven't had too many major presentations in the last several years, but it does profoundly inhibit HBV replication, and with it should profoundly inhibit HDV replication because you're preventing viral entry into the cells and the formation of new HbSAg. And these are the two major trials that we've seen so far, called MIR-204 with bulevirtide at 2 different doses, 2 versus 10 milligrams. 10 milligrams has been studied more recently. It has more favorable pharmacokinetics. And this was a 48-week, 96-week study, except in the PEG interferon group. The second group, PEG interferon plus bulevirtide, 2 milligrams for the first year, and then just bulevirtide, and then the other 2 arms were just bulevirtide, as you probably saw. Well, the primary endpoint was undetectable HDV RNA at 24 weeks after the end of treatment, and I've highlighted those figures for you here. And the 2 main arms that they were concerned about and defined as the primary comparison arms were the bulevirtide 10 milligrams plus PEG versus bulevirtide alone. And you can see that there are substantial differences in the rates of on-treatment response and sustained response. And I think this is going to lead to a very interesting question in the field, which is whether you use interferon or not. That's already being exemplified in Europe, where patterns of bulevirtide use, where it's been approved for about 5 years now, vary from the exclusive use of bulevirtide to avoid the side effects of interferon, particularly in Italy, where Pietro Lampertico is a leading international figure and has done mostly monotherapy, as I understand it, while in France, for example, they say they're using more interferon. So I think this is going to call, more than anything else the AASLD said requires shared decision-making, this is going to be one for shared decision-making when this drug comes out. MIR-301 was a second study, and my same comments are going to apply, but no interferon this time. And again, the results after 144 weeks of treatment, 2 years later, are, as you see, 22% in the bulevirtide 10 milligram group, 2 milligrams in the 20 milligram, 20% in the 2 milligram group, 22% in the follow-up week 96 arms. Or data. And finally, there is a drug that is being developed called tobevibart. which is a monoclonal antibody to surface antigen, so it's an anti-HBs that's purified, and elebsiran, which is a small interfering RNA, such as I showed you for hepatitis B. And in hepatitis D, it's given very impressive results. As you can see, antiviral responses, 97%. Now, you have to keep something in mind when you look at delta data. I'm almost done. But when you look at delta data, the FDA has required as the primary endpoint in the studies a 2 log or more reduction in HDV RNA plus normalization of ALT. That's a regulatory required primary endpoint. The one that I really care about is HDV RNA, which is what I'm going to emphasize here, and many others feel that way. You can see week 48 responses, that being the duration of therapy. Target not detected, 66% with the combination, somewhat lower, but still very impressive at 49%. And I'll leave you with that, except to also add, per the last picture here, that there were promising observations regarding reductions in liver stiffness from the beginning to the end of that study. The next monotherapy, another monotherapy that's being studied, this one with a monoclonal antibody alone for chronic hepatitis D, profound levels of virologic response, 100% in each of 3 different dosing groups, but remember that's 2 logs or more reduction. LLOQ, very robust as well, somewhat lower, but still very impressive, 44%, 30%, and 39% in the 3 dosing arms of target not detected after 48 weeks. And excellent reductions in the excellent results with regard to combined endpoint that you see. So, in the interest of time, I'm going to leave this up for whatever time we can spare until the next speaker gets up. And in fact, the next speaker consists of a group of us with Tony Martinez chairing a panel discussion in which I'm privileged to take part along with 4 colleagues. So I would ask you to come up now. In the meantime, read the slide if you like, but I'm not going to read through it. Thank you.
That was great. So we're going to do something a little different. We're going to run cases, but I think in the interest of time here, we're going to ask a series of questions. So first I want to introduce our panel. So joining us out of Fresno and UCSF, hepatologist, Dr. Marina Reutemann. We have a man who needs absolutely no introduction, one of the giants out of Los Angeles, California, Cedars-Sinai, Dr. Paul Martin. I personally think Ira should just go by Ira, like Madonna and Cher. He doesn't need a last name anymore, just Ira. And then finally we have Dr. Richard Match, co-founder of the Arizona Liver Health and the medical director of Viral Hepatitis, the Viral Elimination Network in Arizona. One of the first hepatologists out of Buffalo, New York. Hell, might be one of the first hepatologists ever. He's my grandpa. So in this talk, Ira, you know, I think what we just heard, it wasn't an update on just a simple update on viral hepatitis. It's really a snapshot of a field in transition. So for a long time with hepatitis B, for decades, we've treated this largely as an inflammatory liver disease, right? And we've been guided by ALT, fibrosis stage, Hep B DNA levels. And it seems like what we're seeing now is really a philosophical shift. So we're moving toward treating this as a persistent viral infection with oncogenic potential. So the question, and this might be the most disruptive question of my series here, but you know, as we move toward treating this as sort of this chronic smoldering viral disease, are we under-treating Hep B by clinging to some of that old dogma, some of that inflammation-driven thresholds, or are we risking over-treatment if we move toward broader antiviral use? And I'll start with you, Ira, and then I want to move to Paul.
We don't treat any other viral infection by anything other than the ambition to eliminate or at least completely suppress the virus if the virus can't be eliminated completely. You know better than I do as an HIV expert that we stopped using CD4 counts as an inflection point for HIV therapy. We certainly stopped using ALT for what became hepatitis C from non-A, non-B hepatitis a very long time ago. And I think we should do the same thing with hepatitis B, acknowledging that certainly with regard to Hep C, but not HIV, it does have a more complicated life cycle. And you could argue that perhaps additional considerations should be kept in mind. But as you can tell from my clearly enunciated preferences, I don't buy into that anymore. And I think, given our knowledge about what integration can do, I mean, there's nobody in the field who thinks that integrations in the hepatocytes are unrelated to liver cancer. Liver tumors in HBV patients are loaded with integrated DNA. And we know that the virus can integrate its gene material at random points, to be sure, but sometimes in tumors we find them near oncogenes, either proto-oncogenic or oncogenes that suppress tumor formation that may interfere with that and allow tumors to grow.
Yeah. Paul?
So I've always felt that every patient with chronic hepatitis B is a candidate for antiviral therapy for all the reasons Ira expanded on. One of the other personal observations, I've seen several young Asian American patients with chronic hepatitis B infection whose first presentation was a fulminant reactivation. And what I tell individual patients, this is a very unpredictable disease, and the one thing we can offer to keep you safe is antiviral therapy. So I absolutely believe that every patient with chronic hepatitis B is potentially a candidate for antiviral therapy.
Interesting. I'm sorry, I forgot to introduce myself. I'm Tony Martinez. I'm also from Buffalo. What Ira doesn't know is back in 2010, in escaping from the volcano, I was driving the bus. So I think it's fascinating that we're talking in part about expanding treatment to treat more individuals, but at the same time, we're also debating stopping treatment in others. It's a bit of a paradox. So Ira, you just showed in Retract B, we saw that stopping nuke therapy, it's not necessarily benign. There were flares, there was episodes of decompensation, especially in cirrhotics. But we're kind of moving toward this era of functional cure. So the question is, how comfortable are you stopping therapy in your BE antigen negative patients with a low B surface antigen? And what does your monitoring strategy look like in the real world if you do so? Again, I'll go right down the line because I'm curious about everybody's opinion here. So start with Ira, please.
My strategy is very simple. I don't do it.
Yeah.
And I was pleased to find that this is one area in which the ASLD guideline and little old me are in complete accordance. If the patient insists, it's a different story, and then I monitor I monitor them very carefully in the first few months for flares. Go ahead, Marina.
I agree with Ira. I don't do it. And I don't do it for a very specific reason. My patient population is very unreliable and very unstable. I practice in California, Central Valley. We see a lot of agricultural workers who come to gather our fruits and vegetables that we all eat here, and they are not reliable in terms of follow-up. So I'm just too nervous to stop the antiviral therapy and have the patient present with a life-threatening flare somewhere in a different state where I cannot reach them.
So having seen a lot of patients from the east side of our community, which is Phoenix, I'm asked all the time about patients, can I stop the treatment? And I get into a discussion, well, you know, if you were diabetic, if you had hypertension, you'd be taking pills every day. Why is this different? But I think in the minds of many of these patients, it is a concern. I think, and Tony, you and I have talked about this, there is a subset of patients that will go through a lot of maneuvers, particularly looking at hepatitis B functional cure, to try to get off medication. So I think there's a demand for that, even though those regimens are complex and difficult. But I think generally, I've had 2 or 3 that pretty much insisted that we try stopping, and I told them it didn't work, it wouldn't work, and it didn't work. So I don't do it, but I have a lot of patients that want to do it.
So I think there is a subset of patients it's reasonable to try a withdrawal of therapy, and Ira illustrated it nicely in one of his slides. So it's patients with an absence of advanced liver disease, with a lower HB quantitative surface antigen, and it also needs to be a highly motivated patient who's going to follow up with you on a regular basis. And there's a nice review, I think, in this month's Hepatology by Professor Young, whose studies Ira quoted extensively, endorsing withdrawing therapy in at least some patients.
So it's important, I think, where the messaging comes across to me is that we have to take into consideration the phenotype of the patient. That shared decision making is very important. And I think that one thing that doesn't get discussed a lot is the potential to lose them to follow-up. Important stuff. So, you know, one of the reasons that we're having this conversation at all is because the future might not involve indefinite therapy as we move toward the race for functional cure. So Ira, you showed us some slides. We saw antisense oligonucleosides, siRNAs, capsid assembly modulators, monoclonal antibodies. Now, you know, we even have gene editing. So, you know, if you had to place a bet, not just on incremental surface antigen reduction, but looking at a way on a scalable functional cure, if you had to pick a platform, which one gets us there first and why?
Well, the chronology is what it is, and the only drug that's shown even a somewhat reasonable chance of sustained response so far, at least as a monotherapy, is the antisense drug that I referred to, bepirovirsen. But the results were quite modest. Of course, to every patient who clears HBsAg, that's a precious outcome. I have no idea whatsoever what the FDA, for example, should this drug come to them, would consider a threshold of HBsAg clearance above which they are willing to approve and below which they won't. And of course, that has to be mixed with considerations of safety, and all of that will emerge eventually.
And do you feel like it would be monotherapy, or do you think that this would be combination therapy?
So absolutely, that is exactly the point that I must make clearly, which is that many combinations have been tried, and it's true that Bepi is not the only drug that has effected sustained clearance of HBsAg. There are others, but they're combinations. So siRNAs will do it if you combine them with interferon at a modest rate, at 10, 15, 20% in some small studies, and we'll see more of that. But you can think of things that you might mix bepirovirsen or other antisense drugs, like the second one that I mentioned, with other drugs as well. It's always the issue of, do you need an antiviral and an immune modulatory? Because we know that the immune system has been chronically, quote, exhausted in its battle against hepatitis B in most chronically infected people. And so there are many immune stimulatory approaches of various natures that have been studied or have been proposed. And where we go from here remains unclear. It's a very wide open field, and it's just fascinating.
So moving down the viral hepatitis alphabet, hepatitis C, we can't forget about it. And Hep B still has a thread throughout the hepatitis C story, right? More of us are moving toward point of care, poking your finger, we give you the full course of therapy right up front. Minimal labs, minimal monitoring, it's all gotten very easy. We have new ASLD algorithms for point of care testing. But the Hep B story hasn't gone away. Reactivation, extraordinarily low, but we still have black box warnings for the potential for reactivation on any medication regimen that we pick. Marina, how concerned are you with this, and what do you do in your own real-world practice?
Oh, that's a great question. And I mean, we definitely should be concerned, but we also do need to remember that the numbers of the patients who did suffer reactivation was very, very low. In my clinical practice, what I try to do for the most part is I see the patient, I start them on medication, because the next time I may have the ability to see them is going to be 6 to 12 months from now. So I do want to start them as soon as possible. I do draw all the labs, and on the outside chance that I do find that this patient has hepatitis B surface antigen positivity, I'll just call them up and start them on anti-Hep B therapy. So that's my approach, and it has worked remarkably well.
So how long does that, how often do you see that happen now?
I've actually never seen it, to be honest.
Me neither.
Yeah, I mean, the rates of true reactivation in the US, it's like 0.1%. It's happened in a handful of cases globally, but these patients had some other reason for the reactivation. So it's not something that we're as concerned about. If you're born after 1991, theoretically, you should be immunized, although, you know, that's in the before times, that's gone. No more shots for you. Okay. Next in the alphabet, D, Delta. We have a few minutes left here. This is arguably one of the most urgent challenges in hepatology. We've seen combination strategies, bulevirtide, monoclonal antibodies. We're finally, I think, seeing meaningful HDV viral suppression and even in some cases sustained response. Durability remains, I think, the question, though. So, do you envision Delta management evolving into long-term suppressive therapy similar to HBV? Or do you believe that finite combination strategies can actually deliver durable off-treatment responses? Ira and Paul, please.
Yeah, we have to remember that HDV is not like hepatitis C. If you take a course of interferon, it's been shown years ago, a famous paper, that relapses can occur way beyond the 24 weeks that we've gotten used to with hepatitis C, mean of 3.5 years. Admittedly small cohort, but there were a number of very late relapsers. So the biology of this is fascinating to speculate about. I mean, Delta doesn't archive its DNA the way hepatitis B does. Where is it coming from after 3 years of complete suppression? Part of the problem was that back then the assays were not as sensitive. Now the thresholds for detection are much lower. And I didn't have a chance to explicitly mention, but at least in one of those studies, it was shown that relapse, in the evolving picture with the newer drugs, let's just say, late relapses seem not to occur, but do depend on, or relapses after the end of treatment can occur, but it depends in large part with how long you were negative on the antecedent course of therapy. And so in the very longest study, the 144-week one, you relapse the most if you only had negative HDV RNA for 24 weeks of that duration, then 48 weeks, and less than 10% of the patients relapsed if they'd been negative for a very long time on treatment.
I think we'll be looking at more protracted treatment regimens for the reason Ira just expounded, to diminish relapse rates off treatment. So I could see patients receiving therapy for a few years and then being followed afterwards.
You know, and if I could just say, I think this is going to drive the decision about interferon. And I love using the phrase shared decision-making, which is all over the B guidelines, but weren't mentioned in that particular, in those guidelines for hepatitis D, but I think that's what's going to go on. Because it clearly gives you a better chance of a sustained response, at least within the time range that we've looked at. We haven't looked at 3 to 5 years yet, except for those earlier studies, because these are too recent. But it does seem that if you want to give the patient a much better chance of sustained clearance, you have to propose to them they take a year of interferon. It's going to be very interesting to see how the doctor-patient interaction plays out in terms of the roles that each of the doctor and the patient have in making that decision. I think it will have to be mentioned to patients from what we're seeing, even if that regimen doesn't turn out to be FDA approved. And the patients will be free to reject it, in which case I'll probably breathe a sigh of relief that I don't have to manage somebody on interferon again.
Brilliant. We'll leave it there. Thank you to our panel. Big round of applause. Thank you to all of you for the privilege of your time.